Hi everybody, how are you? Dr. Emily, podiatrist, human movement specialist, functional podiatrist, fellow in functional medicine, founder of the Evidence-Based Fitness Academy, inventor of Naboso, all this fabulous stuff. All right, what I want to do is take a few minutes to speak to you about heel spurs. What causes heel spurs? Are heel spurs actually the cause of your patient's pain? What really is happening down in the bottom of the heel, and how can you help those patients, clients, and athletes? So, first of all, I want to kick off by showing you an x-ray of a heel spur so that you know what we are referencing. So I will oftentimes have a patient come in and they will write as their chief complaint that they have heel spurs, or they have heel spur syndrome. They've been diagnosed with heel spurs, so they are back again because their heel is hurting them for this diagnosis. So typically what you'll see when you look at an x-ray, so this is trying to do this upside down, this is the calcaneus. So the calcaneus is here. This is what's referred to as the plantar calcaneal tubercle or tuberosity. That is where your plantar fascia originates. It is also where your abductor hallucis originates. You can also see back here, this is the calcaneus. If we go retro, we go behind, you can actually see, do you see that little osteophyte in there, right? So that would be another form of a heel spur. That's lying within the Achilles tendon. The Achilles tendon is continuous through the bottom of the heel and what's called your calcaneal periosteum into your plantar fascia. So that is part of your superficial back line. It is one continuous piece of connective tissue. And what you're seeing in that presentation is this patient having a spur right on that plantar calcaneal tuberosity. Now, that spur is not the cause of the pain. Patients see the spur, they get super excited about the spur, they think the spur looks sharp and that is poking them every time they put their heel on the ground. That is not the case. This spur, think of it as an incidental finding. This spur is telling me, or telling any practitioner, any professional who happens to be listening and treating a patient with heel pain, is telling us that they have too much tension in their plantar fascia, that they've lost the elasticity of their plantar fascia. So essentially that spur is just showing you a reaction of what's called Wolff's Law. Wolff's Law is based on bone responding to tension. So if I keep pulling on a bone, the bone or that tension is going to stimulate the osteoblasts, and that's going to create that spur, the follow through with the line of tension. So the spur, again, is telling us that there's too much tension or loss of elasticity in that plantar fascia and the connective tissue. So what actually is causing pain for the patient is the micro trauma as a result to the loss of elasticity in that connective tissue. What happens when we do dynamic movement, we're running, we're jumping, we need to recoil through what's called a spring mass theory or a catapult effect, where you load the potential energy into your elastic tissue and then you let it go like a rubber band. Now, if you lose that rubber band effect, you actually start to create what's called micro tears. These micro tears create a slight inflammatory response, a peri-tissue inflammatory response, and it creates what's called stickiness, adhesions. Inflammation anywhere in the body creates stickiness, but that stickiness or that inflammation creates a repair process. That repair process, what it does is it stimulates a repair in the collagen, which is what makes up the plantar fascia. But what happens is that your body repairs the collagen of your plantar fascia with a different type of collagen. Normally your plantar fascia is packed with what's called collagen type 1, which is the rubber band type collagen. This is the collagen that you want in your connective tissue. Now when you have that micro trauma, it is repaired with collagen type 3. Collagen type 3 is not elastic like a rubber band. For simplicity, we'll call it like scar tissue. So it's going to be more restricted. Think of it kind of knotted up. Other thing that happens is that when you get that injury, you get what's called a neovascularization. So you get revascularization to the injured tissue, but the blood vessels are going in all these haphazard ways. The collagen type 3 is in all these haphazard ways. So it's not organized, it's a disorganized area. Now what you need to do in your first presentation of an injury, when your body is repairing itself, is you have to get this disorganization organized. And that's where manual therapy, doing releasing, doing eccentrics, starting to get that tissue to lie in the parallel planes that it should be, the parallel planes of its elasticity. Now, if you don't do that and you get this collagen type 3 and this neovascularization, you get a little bit of compromise of blood and circulation to that tissue, you then stress the tissue again and you get more microtrauma. So you get microtrauma on top of microtrauma. You get collagen type 3 on top of collagen type 3, and now you start to fall in what's a chronic state. So now you have a chronic tissue. Perhaps that patient with chronic plantar fasciitis or irritation within the plantar fascial has a big old spur. But again, that's just telling you that they've had this condition for a while. So I like to use the spur as a marker to know roughly how long my patient has been stressing that tissue without addressing it appropriately. Now, if you fall under a chronic state, this can often be seen through ultrasound. So when we look at the plantar fascia on ultrasound, you can actually see thickening of the plantar fascia. A normal plantar fascia is like 3 millimeters thick. As soon as someone gets into a chronic state, you'll start to see the plantar fascia as 5 millimeters. So that's a good way that you can start to gauge the age or the chronicity of a patient's plantar fascia. Now, if you have heel pain in the super acute state, 90% of those patients respond to conservative treatment. Rolling, icing, stretching, anti-inflammatories, orthotics, rest, splinting, banding, rock taping, any of those things that we think of, strengthening foot core, 90% of those patients will respond. It really is that 10% of outliers that fall into that chronic state that are not going to be responding as well. When you start to see that chronic patient not responding, think that 10%, that's where you start to think of like pulling out the big guns, and you want to start thinking about some of the regenerative opportunities. The regenerative medicine opportunities include what's called shockwave therapy. So if you're doing where you're shocking, you're hitting the tissue, essentially you are reinstating the acute state for that repair process to kickstart. You could do stem cell injections. They do very similar. You could do where you do a radiofrequency ablation. It's called topaz, and you essentially irritate or piss off the tissue by poking holes and burning it, slightly burning it, to re-get it into that acute state. Right, so there's different opportunities for you to understand how the body creates injury, repairs from injury, whether it's acute, whether it's chronic, and how to better approach those patients. So, from a quick summary perspective, if you have a patient that says they have heel spurs, oh no, I have heel spurs, I need to be careful, I need to not ever go barefoot because I have heel spurs. One, heel spur doesn't mean anything, so we got to stop, get that out of the mind. It's not what's causing the patient's pain. It is a direct result of the state of that plantar fascia, the elasticity of that plantar fascia. How long have they been irritating and micro-traumatizing that plantar fascia? The longer they've been doing it, the harder job it is for us or any of the professionals who are treating them. If it is in an acute state, 90% of those patients respond to conservative treatment, rest, ice, immobilization, physical therapy, etc. It is that 10% that we need to think about, pulling out the big guns, thinking, okay, if this patient is not responding to conservative treatment after, let's say, a good couple months of physical therapy, and they're not responding like a majority of your patients, you've got to start looking at regenerative medicine options. I hope that you guys enjoyed it. To learn more, please check out dremilysplichal.com or any of my associated companies. Take care, stay barefoot strong.